INTERCEPT AD was a first in humans study, but we incorporated a lot into that study that you may not always see in a phase 1 study. So the study was done in patients. One of the things that the field has learned over the last several years is that a clinical diagnosis of Alzheimer's disease isn't really good enough. You actually have to make sure that people have these amyloid plaques that you can now show with a PET scan. So they were patients. We knew that they had amyloid plaques based on a PET scan. And so when we put them in the study, because it's a phase 1 study, safety is always the first outcome that you're looking for. But unfortunately, and we can talk about this, but the safety profile looks good for this antibody. But because they were patients, we're also able to look at a number of other things, in particular, some biomarkers, both in spinal fluid and in blood. And we're just now getting some of those results. But what we found in the study is that, first of all, there is this side effect for several of these antibodies called ARIA, amyloid-related imaging abnormalities. There's sort of two types of that. There's one ARIA-E, which is where the blood vessels are leaky and you get edema. That's what the E is. There's another one called ARIA-H for hemorrhage. Now, the thing to keep in mind is that the vast majority of the time, these hemorrhages are microhemorrhages. They're just little dots. And by themselves, actually, generally, the vast majority of the time, they're not particularly problematic. It's the ARIA-E that we actually worry about more. Now, the ARIA-E, 80% of the time, there are no symptoms associated with it. You just see it on an MRI scan. But 20% of the time, there are some symptoms. And again, in fairly rare cases, those symptoms can be significant, even leading to hospitalizations and that sort of thing. One of the ideas with our antibody, ACU193, because it targets oligomers but does not target plaques, we thought that there may be little or even no ARIA associated with it. Because very intentionally in the development of this antibody, it was developed to not bind, first of all, to the monomers, the A-beta monomers, but also not to bind to plaque. And based on some other experiments, there may have been a little binding to plaque, but certainly not very much. So when we started the study, we honestly didn't know whether we would have ARIA, and we didn't know whether we would reduce plaques. So if you have an antibody that targets plaques, you want to use these PET scans to show that your plaque load goes down. But in our case, we don't target plaques. So we didn't know whether we would have ARIA, and we didn't know whether we would have plaque lowering. Well, it turns out in the study, we did have 5 cases of ARIA out of 48 treated people. One of those was symptomatic. The symptoms were actually mild and went away really quickly, but there was one that was symptomatic. And so we knew we were having some effect on plaque. And then when we looked at the PET scans on people, both before starting treatment and then at endpoint after treatment, in the cohorts with the two highest doses, we did see some plaque reduction, either 20 or 25%, depending on the dose. So we had a little bit of plaque reduction and we had a little bit of ARIA. But again, our target was these A-beta oligomers. And a group of people at Acumen, I can't take any credit for this, it wasn't me, but a group of people at Acumen developed a very sophisticated assay to show that the ACU193, after you gave it to a patient, that it bound to oligomers. And you would measure the complex of the antibody and the oligomer in spinal fluid from these patients. And so one of the really important findings, besides the safety findings, was that there was a very nice dose-dependent increase in target engagement or oligomer binding across the cohorts. I should probably mention, like a lot of other phase 1 studies, there were cohorts where people only got one administration of the drug. And then there were 3 other cohorts where they had 3 administrations of the drug. So no one had more than 3. In the cohorts where they only got 1 dose of the drug at the very highest dose, which was 60 milligrams per kilogram, we did see probably a little bit of effect on plaque, and we had one case of ARIA. But generally, where we were looking for most of all results were in these multiple dose cohorts. We call them the MAD cohorts, and even with that, they only got 3 administrations of the drug. So this is a phase 1 study. It's not something that runs a year and a half or something like that. So we were really pleased to see, first of all, the safety, and then secondly, this target engagement that was really demonstrated very nicely. It's very dose dependent. And so we know that the ACU193 got into the brain and bound these oligomers. We do have possibly a little bit of binding directly to plaque. Now, this antibody is a type of antibody called an IgG2, which has reduced what's called effector function, but it's not 0. So if an antibody binds to plaque, it can call in microglia, these white blood cells in the brain, and that can essentially attack the plaque and lower the plaque. So that's one possibility, is that we really did have a little binding to plaque, and we really did have enough effector function to get a little bit of plaque reduction. But the other possibility is all these different species exist in equilibria. And it's certainly possible that by binding to the oligomers, you just shifted equilibria so that the plaque, it can go back into solution essentially. And so we may have just shifted equilibria to result in the plaque reduction, which would be consistent with having less ARIA. Again, it wasn't 0, but it wasn't certainly as common as with some other antibodies that have been tested.